And welcome back to the Full Code Case Study Series. Going to try and squeeze in one at the end of this week. We do have the next podcast coming out very shortly on atrial fibrillation in the ICU, so have that to look forward to. And I figure we'll continue doing our full code medical simulation case studies with a focus on kind of a rapid response inpatient instead of, emergency department working somebody up versus there are some EMS cases, which maybe we'll do later. But for now, let's jump on over to the case. All right. So hospital day 2, time 4:55 p.m. Subjective. 68-year-old admitted with pyelonephritis on day 2 of ceftriaxone. Sweet. Afebrile overnight. Vomiting has resolved. Held furosemide overnight due to concern for AKI and volume losses from vomiting on admission. Objective. Pearl. Pupils equal round. Reactive to light. Neck is supple. Lungs are clear. Regular rate and rhythm. Abdomen soft. Minimal left CVA tenderness. 1+ edema to knees. Assessment. Improving on ceftriaxone, urine culture, and sensitivities are pending. Plan is transition to PO antibiotic. Restart furosemide once tolerating oral intake. Okay. Floor nurse. Last shift noted. Patient was fine. Seemed to be improving. Was able to take POs this morning. When floor nurse came to assess, patient appeared acutely short of breath. Started on nasal cannula and activated rapid response. All right, cool. Start. All right. No, I don't want to talk to an AI patient. Thank you for the offer, though. Okay. Before we get into the nitty gritty, I'm just going to do this the way I like to do it. We're going to get the monitor on. Bad news right out of the gate. Tachycardic, hypoxic, tachypnic, hypertensive. Beautiful. So we need to do some temporizing measures right now. Let's start with some supplemental oxygen. A little bit of nasal cannula. Oh, the SAT is still too low. I just put it on. Give it a second. Yeah, it's not really coming up. 86, 87. Can we do a quick respiratory assessment? Bilateral course, breath sounds with diffuse rails throughout. It doesn't tell me about anything about a work of breathing. Neuro, awake and alert, faces symmetric, no drift in upper extremities, yada yada. Okay. Can she talk to me? She's not looking so good. I think she's tiring out. Okay, back to stabilization. Let's get her on some positive pressure ventilation. All right, yes, that's we're plummeting there for a second. Good, patient is on positive pressure. Thank you. Still tachycardic, but SATs are good, up to 98% now with a rate of 11. Still hypertensive. Cute. Okay. So I think we're at a more stable place now. So let's read through. Hospital day 3, time 05:45. Admitting diagnosis pyelonephritis. 68-year-old female with acute severe shortness of breath. Okay, that's the reason for rapid response, right? The progress note, I'm just scanning through it because a lot of it's what I've already read, but it also notes at the bottom, PO trial today, transition to PO antibiotic, restart furosemide once tolerating oral intake. Past medical history, hypertension, heart failure with preserved ejection fraction, hyperlipidemia, lumbar spinal fusion, and colon cancer with a partial colectomy. Current medications include IV ceftriaxone, furosemide, aspirin, lisinopril, carvedilol, ondansetron. Okay. No drug allergies, non-contributory family history, no alcohol or substance use. So what is this looking like thus far? We've called, this patient was admitted with pyelonephritis. They're acutely short of breath. They've stated several times that the patient takes furosemide and didn't get furosemide. And it also notes he's got a history of HFpEF, that's heart failure with preserved ejection fraction. So she probably needs that Lasix. So let's do a quick RS if she can talk to us. I'm still getting some chills. Okay. Patient does not answer due to dyspnea. Patient does not answer due to dyspnea. Okay, so let's do a couple things. Let's get some investigations. Let's see. We're going to get a finger stick blood sugar, even though that's definitely not what's going on here. You always need to do it. You get your rapid response. You always got to check your blood sugar. Let's do a chemistry. I don't really care much for an arterial blood gas, and I'll tell you why in a minute. No. I'll get that, even though I'm pretty sure I know what that's going to say. A little pro-BNP. Okay. And then, you know what, for giggles, why don't we go ahead and get a chest x-ray? No, we pretty sure I know what's going to say. Okay. So, let's start with the chest x-ray. Well, good. Although they gave us an interpretation. Increased interstitial markings consistent with pulmonary edema. We'll get a little zoom in on there. Yeah, you can definitely see the pulmonary vasculature is prominent. Normally, if this was a real case, we'd be, really looking through this image. But honestly, this is probably just a generic image of someone with pulmonary edema, pulmonary vascular congestion. So we do have a markedly elevated BNP. Not crazy high. It's just 1,017, but high. Chemistry, sodium good, potassium, okay, chloride fine, bicarb 26, cool, BUN 40, creatinine 1.76, glucose 100, finger stick blood glucose is okay. So, all right, so we're hypertensive. So we're dealing with, she has an acute kidney injury. She was admitted with pyelonephritis. It didn't really tell us anything about what her urine output and stuff look like, but she does have some edema. I think it said around the knees specifically. We can look and see. Let's do a quick exam. Neck, JVD to the angle of the jaw. No masses, trachea midline, supple. Okay, JVD. So we definitely have volume overload, right? Let's check, do a cardiac exam. Tachycardia, regular rhythm, no murmurs, rubs, S4. Okay. So she has all the makings of a multifactorial volume overload. So the first being that, and again, we're just making an assumption because it doesn't really specify some of the details of the care, but when you have acute kidney injury, pyelonephritis, maybe it's secondary to like an obstructive uropathy, so you're not getting urine output, not getting urine out anyway. You can definitely develop this volume overload, and then that volume overload just translates throughout the system. And in the setting of already having heart failure, we're kind of in a weird kind of gray zone in terms of, I don't want to say like chicken or the egg. It's pretty clear that this is at the core of it. It's a volume overload problem with pulmonary edema. That's probably driven by both the heart and the kidneys. So let's do a couple things. Remember this. An elevated creatinine is not an absolute contraindication for diuretic administration. You will hear, like, for example, in this case, right, that we didn't say, but the case said they're concerned about her volume loss because of the vomiting, so they decided not to give her furosemide. And in the setting of an AKI, which is not like bad rationale, like it's something that you would absolutely consider. You don't want to make something worse. I will say this, I would maybe consider guiding that distinction with a little bit of laboratory data. If you think that you have severe enough, let's say vomiting or diarrhea, some form of loss in that way, you want to look for the signal that it's severe enough that it has caused some form of metabolic derangement. Now, can you be volume deplete and not really have crazy metabolic derangements? Sure, you can. But I would say if it were severe enough that I had a patient with heart failure who needs Lasix, I'd probably still give them, you do your fluid resuscitation, but fairly quickly you're going to make sure they get back on their therapy, especially when something like this starts to manifest. This is like case in point where, and this happens, and I don't necessarily, like, sometimes, yeah, people are at fault for not restarting medications too soon. But, especially in the ICU, we admit patients to the ICU and then stop all their meds, like basically, like right out of the gate. Often that's because there's, multi-system organ involvement, and it's different kinds of shock, and you're not going to throw drugs in there that aren't going to be metabolized or excreted very well. That wouldn't play very nice in the current disease state, whatever it might be. So very commonly you get admitted to the ICU, and then a lot of your home medications are stopped. And then sometimes when you're looking, you're looking for like, when is the coast clear? Like, when are we good to restart? And a lot of times it's going to be based on labs in general. So, and obviously we have some whack, not a ton, but we have some whack labs on this. But you're going to be looking for some normalization component, making sure that it won't precipitate a worsening problem, right? So if you have somebody who, takes a bunch of ibuprofen on the daily because, like in her, let's just say in her case, she's had a lumbar fusion. Some of these people take ibuprofen around the clock just to try and help them out. So if it's a quote unquote home med, right, and they come in with an AKI, you're going to stop it. Now, should you restart it? Well, first you have to do investigations, right? Like, and that's a whole rabbit hole, but you need to find when the coast is clear or what a good alternative agent is. So in this lady's case, she's not been in the hospital for too terribly long. And obviously there's a lot of things that could have happened that we don't know about, but she had an AKI and she was vomiting, and that could be more than enough to assume that she's, volume deplete. But obviously in her case, we have to look for other things that can flip it the other way. And there is also such a thing as being, extravascularly overloaded and intravascularly overloaded, right? Like, you can be very edematous but be intravascularly dry. I know it's a contentious area. Some people don't agree with that at all, but we're going to run with it for now, because that's a generally accepted understanding of a thing that can happen, which is why there are certain salvage strategies that we have where we're trying to, for example, forgive me because this is even more controversial, right? The whole albumin Lasix deal, we're trying to pull and push, get things back in the vasculature, get it excreted. We know that doesn't really do that, but who knows? Maybe it helps. Maybe it doesn't. There are a lot of ICU and medicine isms that, fortunately or unfortunately, still exist regardless of what some guidelines have said. So there's that. Not that I don't even know that there's a formal guideline that says don't do Lasix and albumin, but that's a good question to research. Is there anything that says don't do it? There's a difference between saying it won't help and don't do it. So let's get back to this lady. So she's just sitting here staring at me. We're going to give her Lasix anyway. Oh, I already gave her some Lasix. Let's go. And she's on positive pressure. And then you know what? We're going to give her some nitroglycerin as well. Boom. Help you out, lady. So, I'm trying to figure out how to say this without making it terribly confusing. There's a lot of triads, not triads specifically, but a lot of different constellations of symptoms that you may see, and it's easy to have like a knee-jerk response and say, oh, this thing exists. So for example, not uncommonly, like post-surgical patients, post-trauma patients and stuff like that, they can be, for whatever reason, any number of reasons, they can be maybe a little bit acidotic, and then have a stress hyperglycemia response to whatever's going on. So I've been asked, and even as a newer provider, I get, you never want to miss anything, right? So we see these patients and they have an elevated serum glucose, and then they also have a metabolic acidosis, and people go, oh, do they have DKA? And it's like, no, probably not. Like, clinical history, course, context, everything matters. So those two things can exist, independently of each other. They don't always have to go together, which is what I'm trying to say. So to apply that concept to this situation, we have shortness of breath, pulmonary edema, tachycardia, and you can take that in isolation, and then hypertension and go, oh gosh, is this, pulmonary edema secondary to like a hypertensive urgency? So, when you have that big elevation in systemic vascular resistance in the setting of severe hypertension, that fluid just backs up, goes to the lungs, right? So next things you can consider that you could think about as acute decompensated heart failure. Like that's not the worst idea in the world. You do have JVD, bilateral lower extremity edema. You have tachycardia. You have hypoxia. You have and a little bit of hypertension. So, and you get down the road of like hot shock, cold shock, or like in the setting of heart failure, like the phase like hot and wet. So, you can start thinking, and obviously in this case, actually, I didn't even look. Can we do an echo? I don't think we can do an echo. I don't know that it'll honestly benefit much, but just for the sake of, nope, can't do an echo. So, you can have these patients that have, you know that they have heart failure, and then let's say they come in, their EF can be 15 to 20%, and people will go, oh my gosh, cardiogenic shock. And it's like, no, you can have just a cardiac low flow state. That's not necessarily shock. And these same patients can have, a systolic blood pressure of 140 and look warm and perfused, but they can also be floridly volume overloaded. So in this case, again, these are all multiple overlapping entities. I would not characterize this as acute decompensated heart failure. I think this is volume overload, which is multifactorial, like we said before. So we've given her nitro, we've given her Lasix, we put her on positive pressure. Let's see. I wonder if she can talk to us yet. I don't have any chest pain. I'm feeling much better already. Thank you. Okay, so some of these questions she'll answer, some she won't. So most of them appear to say no. So I'm not going to click any more of those. Exam wise, just for the sake of completeness, let's see. We did, I like to do a full exam. I just do. Nothing abnormal. +1 putting edema to the knees bilaterally. Yep, we knew that. Anything going on with the skin? Warm and dry. Cool. Love that. And neuro, fine. And psych, unable to restore. Okay. So let's move through this systematically. Any additional stabilizations? I don't think so. She has IV access. This is not a situation in which we feel like we need to do high volume or rapid volume resuscitation. So I don't think we need another line. She clearly doesn't need chest compressions. She's on supplemental oxygen. She doesn't need fluids. Doesn't need to be intubated right now. Stop intubating people. For our investigations, we already got an X-ray of the chest, BNP, so we know what it is. We got a chemistry which did show a little elevated creatinine, a little azotemia there. Not really much to do. I mean, we did have to diurese her, so we'll need to keep a close eye on her creatinine. It may get worse. It may also get better. So, gosh, we won't uncork that genie, but maybe one thing we'll probably need to talk about it one day, where when you have states of extreme volume overload, how that causes end organ damage, and its impact on like afferent, efferent renal flow, the RAS system, the like natriuretic system. Those are all things that you look at and consider in certain circumstances, because this is a volume overload problem. Sometimes when you relieve that volume, it can downregulate an overactive RAS system. It can help change the renal flow dynamics and help decrease kind of the constrictive mechanism that's in place. So we'll follow the renal function. That's the short answer. Any more meds? I don't think so. Some people might say because of the shortness of breath, might say get an EKG and troponin. I feel like I'm just going to go ahead and do these just so I can say that I did, in case it's like, hey, you should have done this. So let's get troponin too. 0.05. Cool. EKG, very blurry. Very blurry. Looks sinus, CP waves. I don't see any marked ST elevation. Everything is upright and pointing in the correct direction. Okay. So I think this patient, let's diagnose them. That's not going to be a volume overload. Let's say pulmonary edema. Acute pulmonary edema. And then let's communicate to cardiology because we're good friends. Cardiologist recommends admission to the ICU. Yeah, we know that. If you hadn't already done so, make sure to control the blood pressure. Already done. Do we need to call critical care? Is there critical care on here? No. Okay. We'll go transfer to the ICU, acute pulmonary edema. Don't think there's anything else we need to do here. Let's see. Finish. 96. Let's go. Okay. So let's break it down. Review of systems is obviously irrelevant. Not irrelevant, but not obtainable in this situation. Examinations 100% shocking. I did them all. Stabilization 66%. What? 66.7. Okay. Attached monitor critical. Nailed it. Nasal canyon oxygen neutral. Okay. Non-invasive positive pressure ventilation critical. Agree. Second IV. I just got done saying why I didn't need a second IV. An unstable patient should have additional IV access. I'm not going to disagree with that. Like, you probably should. It's not the worst thing in the world. There's no, you know what? Looking at this from the perspective of just volume resuscitation alone isn't necessarily the best view. Having additional access is always good in a critically ill patient in case one of your accesses go bad. So that would be a counterpoint. So sure, critical. I wouldn't call it critical. I'd call it important, but I wouldn't call it critical. Investigations, fingerstick blood glucose neutral. Don't get me started. Troponin was actually recommended. Let's go. So basic chem critical, pro-BNP critical, XR chest, ECG, and troponin. Anything? Nope, nothing else. Cool. Interventions, furosemide bolus recommended, which we did. Antihypertensive treatment, nitroglycerin, nicardipine, labetalol, nitroprusside. So I think that's kind of worthy of thinking about for a minute, because kind of everything has positives and negatives. And then depending on what the clinical scenario is, nitro, one of the reasons we picked nitro is because it's a vasodilator, meaning, and primarily a venodilator. So in the setting of, let's take it to hypertensive urgency with acute pulmonary edema or flash pulmonary edema. You're having this massive fluid back up into the lungs. You want to introduce positive pressure to open up the alveoli, push fluid out of them, and then give them Lasix to try and push it off. Now, the nitro helps because whenever you introduce positive pressure into the circuit, it changes your hemodynamics, right? So you're having more pressure. You have more pressure on your, you have more resistance against your left ventricle. It changes your RV afterload status. So there are certain patients which you would be very, very cautious about introducing positive pressure onto. So a good example would be like critical aortic stenosis. We'd be really nervous about that. Honestly, we're really nervous about anything that affects their hemodynamics, but we want to help offload the heart and mobilize fluid. That's kind of the goal. Nicardipine, labetalol, nitroprusside. I would honestly be pretty careful with the labetalol drip. I've never used one. It's done. I've never used one. I've never seen one used. Nitroprusside drip, it's just really fallen out of favor for the most part. I don't think I've seen a nitroprusside drip in like 10 plus years. Which we could talk about, but you could do a whole video about that. So anyway, we nailed it. How about for giggles, we'll do Doc Turtle. All right. Doc Turtle number 353 for July 4th, 2026. A 32-year-old male construction worker presents to the emergency department with right eye pain, tearing, and blurred vision. So putting construction worker in there feels very specific. So what could it be? Foreign body conjunctivitis? Let's try that. Nay. He reports he was not wearing safety goggles and was using a nail gun on a metal bracket when he felt a sudden sharp pain in his eye. Why don't we just say globe rupture? Well, that was easy. Okay, visual acuity is, let's go through them. Visual acuity is reduced to hand motion only, and there's diffuse subconjunctival hemorrhage obscuring the underlying sclera. A slared blood collection is noted inferiorly in the anterior chamber, so hyphema. On slit lamp exam, the pupil is peaked in teardrop shape. Yeah. Fluorescein strip is applied near the area of concern and examined under cobalt blue light, revealing a dark stream of clear fluid washing away the dye from the ocular surface. So it's clearly evidence of a communicating injury. So, well, that was a little anticlimactic, I guess. Well, thanks for tuning in. Like I said, we have another podcast dropping this week on atrial fibrillation in the ICU. If there's anything that comes up in these videos that you want discussed in detail, just drop a comment below. Please subscribe, share this with your friends. If you find this helpful, let me know. If you want us to do anything different, also let us know. We appreciate your continued support, and that's all for today. See ya.